All right, everybody, if they could take their seats, please. How's that? All right. Good afternoon, everybody. Hope everybody enjoyed the session and lunch. It is my absolute privilege to introduce my friend Halinder Mangat. Dr. Mangat is a neurointensivist at Kansas University. He focuses on global health and neurotrauma through, in quotes, frugal innovation. He is director of research for the Brain Trauma Foundation, providing both clinical expertise as well as methodological expertise. For those of you who are not familiar with the Brain Trauma Foundation, we will learn a little bit more about it, but it really is one of the leading organizations that has done a really, I think, in my opinion, really excellent job of not only creating guidelines, but also disseminating them for wide use. He is the leading PI for the Brain Trauma Foundation's first clinical trial, and he's going to talk to us about the current experience or the past, present, and future experience of the Brain Trauma Foundation. Thanks,
Hal. Firstly, thank you very much for having me here. It's an absolute pleasure, honor for neurologists to be able to speak at a trauma surgery conference. And I would really like to thank the patient, family, and advocates who've been here. It's been a very insightful experience to hear from all of you and the courage it takes to be involved in working with us folks. So I'm tasked with speaking about the Brain Trauma Foundation guidelines. The Brain Trauma Foundation has historically put together guidelines for the management of head injury, more towards severe head injury. A couple of disclosures. I am funded currently for guidelines from the DHA. I'm a relatively recent addition to the BTF, about 2 years ago. The BTF has existed since 1997. The learning objectives for the talk are to be able to list gaps in implementation of evidence into practice and to assess the overall pathway from problem identification to real-world outcome impacts for TBI. So what were the BTF goals when it was founded back in 1997 by Jam Gajar, who led fundraising and got together some of the brightest minds in neurosurgery in a room. That in itself could be a paper, but they got together to do some great work. It became the first surgical organization to publish a set of guidelines for management of a disease. And the most commonly used product is the guidelines for the management of severe TBI. There are 4 editions, the first in 1997, and the last iteration was in 2017. There will be a revision coming up in probably about 3 to 4 years. There are other guidelines the BTF has produced, early indicators of prognosis, combat guidelines, surgical guidelines, concussion, severe TBI, pediatric TBI, published 6 months ago, pre-hospital management, and I have the honor to work with some folks in this room, going to press probably in 2 months, penetrating TBI, which is actually the first edition, not written by BTF, was written 23 years ago. So the underlying process has been the theory of change. If we want to improve outcomes after head injury, so identify the problem, what are the activities we need to indulge in, what the output would be, how do we measure the outcome and the impacts. In real world, I may not be able to read my own text. So the problem is the mortality and disability due to trauma, and we've also heard about the economic impacts of it. The activities is the epidemiological assessment of burden of disease, the government allocation of funding, and ongoing research activities. Outputs being evidence and guidelines. And unfortunately, in the vast majority, outcomes have been extrapolated population benefits from trial data And we know the effect size in trial data is significantly in excess to what happens in the real world. So the impact, by and large, in publishing a guideline set remains to a certain extent unknown, in addition to the temporal delay in the implementation. So this paper from in the New England Journal from 20 years ago basically looked at a set of guidelines for, I believe, in primary care, and concluded that the deficits we have identified in adherence to recommended processes for basic care pose serious threats to the health of the American people. Strategies to reduce these deficiencies are warranted. Serious threats. And this is for data and guidelines that already exist. So we've heard about the 17 years. It takes 17 years to, the second part of the 17 years is to adopt 20% of high-level evidence into practice. So not only is there a temporal delay, but there is also a magnitude reduction in adoption. When a guideline is published or an RCT done, there's a calculated internal rate of return, which is estimated to be 39%. 9% of the economic benefits are from direct impact from results of the clinical trial. 30% is spillover benefit from spillover into the neighboring areas. A delay to adoption by 10 years reduces the internal rate of return to 13%, and a delay to adoption by 25 years reduces the rate of return to 6%. So in a way, if we're taking 17 years to adopt guidelines, we're actually just throwing money away while we talk about trying to get more money from the government. So how's the BTF tackle this in the past? Again, my disclaimer, this has happened before I joined the BTF. So the implementation of evidence, the part that gets probably not enacted is the monitoring and evaluation. So setting the vision, what was the vision? The vision was very simple, was to reduce mortality from head injury. We defined the results model and results-based framework. There should be planning for monitoring and evaluation, implementing and using the monitoring, managing and using evaluation, going back to resetting the vision. And then in the middle is the stakeholder participation. I think one of the reasons why the BTF has been successful is at all levels, we have engaged in the past with stakeholders. One of our most beneficial partner has been the Defense Health Agency, because a lot of these guidelines have been adopted by the military. So at every level of even proposing new guidelines to be done, we have a person from the DHA in the room and on sometimes even on steering committees. We've just had 2 5-year awards, which are a partnership with Uniformed Services University. So evidence-based policymaking is not like evidence-based medicine. So how far should you go to bridge the divide between evidence and policy? So effective actors combine evidence with manipulative emotional appeals to influence the policy agenda. So I'm sure everybody's seen commercials on TV to adopt a dog, and it's a very emotional appeal. But if we were to put it back to back with adopt a child, adopt a dog, and so on, the relative impact changes. But when we watch it alone, the Kennel Association does a very good job about putting emotion before other evidence. And scientists, on the other hand, we tend to be less emotional, and make very factual arguments, which don't always sit with policymakers. Policymakers are often influenced by their local public bodies, interest groups, and service users. And every policymaker has a pet agenda, pet problem they'd like to tackle, which is, again, based on emotion. So successful engagement in evidence-based policymaking requires not only pragmatism and scientific evidence with governance principles, but also persuasion to translate complex evidence into simple stories for policymakers. So here's a very good success story. I know some of you might cringe at this tranexamic acid in trauma. I was lucky. Ian Roberts was my mentor for a while in London. He's done 4 studies with tranexamic acid, actually 6, 2 were negative, and they're now in phase 4 for the CRASH trial, CRASH 4. So they did the classical phase 1 studies, phase 2 studies. With tranexamic acid, there were 2 positive phase 3 studies, CRASH 2 and woman study, which is peripartal hemorrhage. And they disseminated this worldwide, and then they approached the WHO, and tranexamic acid was put on the list of essential medications. And now it's used in villages across the world, because in addition, after publishing phase 3, dissemination and the advocacy was the key part of getting this adopted. So here's how the BTF take the first edition with a vision in 1997. So it's the first surgical society. So setting the stage for guidelines. The BTF implemented a TBI track registry in 22 trauma centers in New York State in 1997. This was funded by Medicare. And what did this set the stage for? Some sort of data elements and the fact that quality assurance should be part of providing emergent acute care. They demonstrated compliance to guidelines was proportional to mortality. And if we were to look at it, this is comparative effectiveness research 25 years ago, even though the concept is now more recent with that name. It generated better quality evidence, retrospective analysis of prospective collected data, and this helped in improving the subsequent guidelines, but established the BTF as an authority in TBI guideline formulation due to the high quality methods, methodologies, as well as vision. And all this helped to improve the next iteration. And this is the data. You can see at the bottom, you can see the case fatality and mortality rates and the adherence to ICP and CPP. The mortality in New York State dropped from 27 to 13%, 2-week mortality in severe head injury. CDC shows 50% reduction, and more recently, the EPICS study showed 50% greater survival in severe TBI and intubated severe TBI. So what happened after the 4th edition? Well, it was sort of the same omelette. It got a lot of criticism. You know, the ICP threshold went from 25 to 20 to 22. I mean, is this really revising the guidelines? And how do we make them user-friendly? So a partnership was formed with Civic, Seattle International Severe TBI Consensus Conference. And for the first time, they created an algorithm of how to use the guidelines. This algorithm has been downloaded 75,000 times in the last 4 years and can now be found in lots of neuro ICUs. Posters were generated that are just pasted to the wall. So it's the next step in making it user-friendly. So what are the new frontiers in what we're doing? we're starting to look into AI tools. The user experience, henceforth, every guideline will come with an algorithm on how to use it. The dissemination, we have web-based courses, and I believe we're working with the SCS for penetrating TBI. And monitoring, we're working on trying to integrate some sort of a monitoring backend into clinical charting systems where we can keep or systems can keep a track. The last frontier, BTF has, if you will, always collated data and created guidelines. So we've just been funded a year ago to conduct our first RCT by the BTF, clinicaltrials.gov. And I'll end right there. We're just but a part of the whole puzzle. Thank you.